Hi, everyone, and welcome to today's webinar, How to Build a Viable Health Equity Strategy, the Tech and Processes Healthcare Needs. This is Mackenzie Bean, Managing Editor at Becker's, and on behalf of Becker's Healthcare, just want to thank you all so much for joining us today. Before we begin, I'd like to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation and panel, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box that you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or you have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box, as we are also here to help. With that, it is now my pleasure to welcome today's speakers. Joining us today is Amy Fellows, who is a Senior Consultant at Pivot Point Consulting. Dr. John Showalter is the Chief Product Officer at Jvion. And Dr. David Bonnet is the System Chief Medical Officer for High Reliability Medicine at University Hospitals of Cleveland. Amy, Dr. Showalter, Dr. Bonnet, thank you all so much for being here today. Really looking forward to the discussion. So with that, Amy, I'll turn the floor over to you to get things started.
Great, thank you. I'm Amy Fellows. I'm with Pivot Point Consulting. We are proud to be recognized as best in class for our suite of services, including our advisory, EHR, EMP to revenue cycle, and managed services. And a little bit about me, in addition to my current role as Senior Consultant at Pivot Point Consulting, which I kind of landed in health IT after getting my master's in public health and working for a kind of a new start organization that was coming out of an Oregon Medicaid managed care organization called OCHIN, which was providing health information solutions for federally qualified health centers and school-based health centers and public health departments. And is now, I think, in almost every state in the country supporting these kinds of organizations. I also spent 5 years as part of the Open Notes team out of Beth Israel Deaconess Medical Center, supporting Open Notes, which is not a product, but a concept of providing patients easy access to the provider chart note for more transparency and to better support patient care. I was focused on vulnerable populations in that role, and since 2017 have been part of the Pivot Point team. My other hat, I'm the executive director of a small nonprofit called We Can Do Better that was started by our former governor in Oregon, John Kitzhaber, in 2006 as a healthcare civic engagement organization. And I'm going to talk to you a little bit today, give some overview on social determinants of health to kind of set the stage for the focus presentation with Jvion. So just to kind of level set here, social determinants of health as defined by the CDC are conditions in the places where people live, learn, work, and play that affect a wide range of health risks and outcomes. And in the Healthy People 2030 uses a place-based framework that outlines 5 key areas, including healthcare access and quality, education access and quality, social and community context, economic stability, and neighborhood and built environments. I would love to, if you don't already know about Dr. Kamara Jones, introduce you to a little bit of her work. Dr. Jones coined the phrase social determinants of equity. And this is a little bit different than social determinants of health. This slide here kind of outlines the differences, where social determinants of health are focused on medical care and public health systems, but then looks at intersections with other sectors, which including education, housing, labor, justice, transportation, agriculture, environment. Social determinants of equity are looking more at structural issues and involves monitoring for inequities in exposures and opportunities, as well as disparities in outcomes. So this is really where we're looking at health outcomes, involves examination of structures, policy, practices, norms, and values, and requires intervention on societal structures and attention to systems of power. So when we're doing our work to really make a difference in health outcomes, we really need to look at both. We need to address the social determinants of health, which include poverty, in order to achieve a large and sustained improvement in health outcomes. And we need to address the social determinants of equity, which include things like racism, in order to achieve social justice and eliminate health disparities. Just in April, just a little over a month ago, can't believe it's June already, CDC director, the CDC declared racism as a public health threat, pointing to the disproportionate impact of COVID-19 on communities of color. So really, this pandemic of COVID-19 really put the magnifying glass on our epidemic and pandemic of racism that really, and this experience in this last year, I think, highlighted it in a way that people cannot deny any longer. The CDC's declaration came from a lot of activism that happened at cities, counties, and state levels. If you look at this map from the American Public Health Association website, it's pretty current because I live here in the middle of Western Oregon in Lane County, and our county commissioners just made their declaration of racism being a public health crisis last month in May. So this is a pretty current map as these things are happening across the country. So this led to the CDC's declaration. And I think the question really is, now that we are recognizing this as a true public health crisis, and especially after last year's murder of George Floyd and the reckoning that has been happening for the last year, I think folks probably know that the last couple of days has been the 100-year anniversary of the Tulsa, Oklahoma, and Black Wall Street, the domestic terrorism that happened there. So really, this is a long time coming. So the question is, what do we do with these declarations? How do we make a difference here? So in Oregon, we have a bill that has gone through our House and Senate and is now in the budgetary process, called House Bill 2337, and that's our own declaration of racism as a public health crisis in Oregon. And it's kind of a threefold approach. Representation and policy, agency, and health system decision-making is one key piece of it. And if you think within your own organizations and looking at where you might have representation in your systems and policies and staffing at the highest levels and all the way through, does your provider mix represent the patients that you're serving? So that's one approach. Mobile clinics is the second approach. So having clinics that go out to the populations that you serve, using community health or traditional health workers as an approach to really working with the clients that you serve of different ethnic groups and populations. And then the third piece, which kind of folds into the next piece of the presentation from Dr. Showalter, is the real D data, which is race, ethnicity, language, and disability, and that is in addition to the SOGI, the social, sexual orientation, gender identity data that is a requirement. And this concept of the real D data in Oregon started in 2013, and we're just now getting to the point where it is getting rolled out across the state, across hospital systems, clinics, etc. And really what this is getting down to a more specific level when you're looking at race and ethnicity. So like Asian American is a very large group that could include all kinds of different people with different environmental exposures, different health needs. So really drilling down specifically to who you're working with is the idea behind the RealD data set. And I'm going to turn it over to Dr. Showalter to talk more about the Jvion product with the social determinants of health.
Thank you, Amy. I appreciate the discussion and the understanding of the challenges that we are facing when it comes to equity and social determinants of health. So Jvion has been working in social determinants of health for over a decade as a company, years old, and have always included social determinants of health into our artificial intelligence and our understanding of what is likely to happen to an individual. In 2019, we really began to hit critical mass and be able to really, pull back from the clinical data and look at just the social determinants of health data in order to understand, what was going to happen at an individual level. And so by that we mean we had about 10% of the U.S. population inside the Jvion core. We had, EHR clinical data, claims data, and then also social determinants of health data on those individuals that either we had, got through geospatial mining or were otherwise publicly available. And we took that information, just the social determinants alone, and the AI's ability to infer, to determine what was going to happen clinically. And really the basis for that was an understanding of the individual. As we looked across how people were approaching social determinants of health, community needs, frequently there were two routes to get it. You went and interviewed individual people, and then everyone in that community assumed the characteristics of everybody that you interviewed, or you had community data, census tract, county data, and everybody, was put into the same bucket as, this is what's going on with this individual. We took a different approach and got individual level data, neighborhood level data, and pulled that together to predict and understand that the individual, which would have then allow us to build populations of individuals and then 2 counties. We were very successful at doing that. As you can see here, if you guys are familiar with AUCs, it's the C-stat. It's how accurate is the prediction. Typically 0.8 is considered, good to very good. As you can see here, we were, good to very good at predicting, inpatient or ER admissions. Notably, the ability to predict those AHRQ-defined avoidable admissions, about 13 different, diagnoses driving admissions, but around chronic disease, CHF, COPD, diabetes, and even with no clinical information, just the social determinants of health and the risk that they have for actually driving chronic disease and driving poor chronic disease outcomes, we were able to accurately, predict with a sensitivity and specificity over 70%, who was going to have a inpatient admission. We did that by looking really deep and broad at the social determinants of health. So we considered air quality, income, neighborhood and migration, transportation, purchasing channel preferences, health literacy. Not going to read the whole list, but things that are not always considered in these scales: digital fluency, retail access, whether or not people are living in group living quarters, things like dorms, nursing homes, prisons fit that category. And then, you can see that under the demographics, really drove down the influence of gender. really drove down the influence of race and ethnicity in understanding, and even age, which has a higher weight than the other ones, is actually much lower weighted than is used in other utilization predictions. So understanding, the social factors that are associated with age or race or ethnicity and what that means to an individual allows us to understand, where they're headed and what their overall risk is and what those driving factors of risk are. That allows us to get to an individual view where, we can look at a population and we can stack rank, 10,000 individuals and say, Mr. Jones is in the 67.3rd percentile versus Ms. Smith, who is in the 99.9th percentile of risk from social vulnerability. And to us, vulnerability is really, a not necessarily changeable or modifiable state, but an addressable state. So just like if you look at vulnerability in the cybersecurity world, you can't necessarily change that, an individual has a mobile phone, but you can put software in that mobile phone that allows you to reduce the likelihood that it gets hacked or stolen, or biometrics on it to reduce the likelihood that someone gets access to it. The vulnerabilities that an individual has can be addressed, especially when you understand at an individual level what's driving it. So, here for this example, it's short-term residency length, their education, their air quality, their likelihood to be digitally fluent, and the lack of other adults in the household. Something like likelihood to be digitally fluent is a double-edged sword. Sometimes it's really beneficial because they can get on the internet, they can find out good information, they can connect with peers or people like them or other people going through their same experience online, but it also means that they're exposed to, poor advice and to solutions that may not actually help them. And you may also have, increased risk for depression or mental health concerns if you are at the extreme end of digitally fluent. That's been proven out in the research. So a lot of these factors are double-edged. They're not all necessarily good or necessarily bad. Clearly, there are ones like being impoverished that are clearly bad, but something like short-term residency length, that may matter if you've just moved in with your family and now you have a lot of social support versus you've lost your job and had to move to a less safe community. So that short residence length needs to be contextualized to understand the risk. We got to this level, and you'll see that the American Journal of Managed Care was published in January of 2020, put us in a really good position to respond when COVID-19 hit, and we needed to pull back from the individual and look at the community and understand that across the country, every neighborhood needed to understand their risk. Health systems need to understand at a granular level their neighborhood's risk. So we were able to, just as we had inferred the clinical information from the individual social determinants of health, we were then able to infer the individual information from just the community information and make very accurate insights into COVID vulnerability, the likelihood that someone was going to do poorly in this neighborhood if they contracted COVID-19. This was originally a response to a call after the H1N1 pandemic, where the CDC pointed out that from a health disparity, health equity standpoint, they didn't understand communities well, and that resulted in those that were most socially vulnerable having a mortality rate that was 3 times as high. Got a lot of use from this. We peaked at like 2 million hits in one day. It was used by FEMA, the CDC, the Federal Government Task Force, the Atlanta Food Bank, local states and municipalities, and that's because the insights, were very strong. So if you look at this area that says, Woodbridge Estates, the area purple is highest risk. The area around it's relatively low risk. Woodbridge Estates is actually a senior living center. We didn't do it based upon age. We didn't train the core to go and identify senior living centers. but it did identify, those characteristics that would highlight a senior living center so that this community, could go and tackle that individual block group as needed. And you might say, well, yeah, we knew nursing homes were a problem, but if we dig into Los Angeles, we were able to really identify the increased risk of the homeless. So overall in California, relative to the rest of the state, Los Angeles County wasn't very high risk as a whole, but there certainly were block groups that were extremely high risk. The area of homeless with Tent City, again, was very dark purple, was very high risk. Again, we didn't train the Corps to go and look for homelessness. We trained it for the characteristics that showed vulnerability, and that translated to understanding, that prisons were at risk, that nursing homes were at risk, that areas with heavy homelessness were at risk. So that granular level and ability to tackle at a county level and on a block group level really moved into the ability to tackle and develop programs around social determinants that could really move the needle for outcomes. So we did work with Oklahoma and Oklahoma Medicaid to dig in, and what we did there is we, took all of Oklahoma, scored its counties on a scale from 1 to 6, 1 being the lowest vulnerability, to 6 being the highest vulnerability, and then looked at whether or not from Medicaid that correlated with important outcomes. One of their most important outcomes was the per member per month cost. Total cost of care is a metric that's charged. That is a challenging metric to use because people may have, and counties may have a lower per member per month cost due to underutilization, due to mischaracterizations of their risk. But what we saw here was that on average, we were able to explain over 95% of the variation in per member per month cost by correctly understanding the social vulnerability. That allowed us to define, expected. So a relatively good estimate of what that county's per member per month cost should be given their social vulnerability. That allowed us to address that, underutilization, better than expected factors by coming in and doing a observed to expected analysis where, if you were, within 5% of expected, you got defined as expected. If you were, within the next 10%, then you were better or worse than expected. And then if you were 15% or more off, you were much better than expected and much worse than expected. This analysis allowed us to really understand what was driving the poor performance of some counties, relative to their vulnerability. And you can see that the counties that were performing poorly, 1 here is worse, -1 here is most helpful. So red is bad, green is good. You can see that for income, those that are doing worse than expected, income was a risk. You can also, see that transportation costs were a risk for the counties that were doing worse than expected. You can also see across the state, food access was an issue and was not necessarily driving over or underperformance, but was a challenge across the state. So we went in and then did a regional analysis, not just an observed to expected, but what's going on in each region. You can see that the OKC, the Oklahoma City region, and the Tulsa region really did have drivers of risk coming from education and food access, as opposed to the drivers of risk in the East, which are really around income and housing, or in the West, which were much more around employment access and access to food as a combination. So getting into the counties and being able to do profiling allows us to say, hey, look, there are these regions that, really seem to be vulnerable to access to food. There may be other regions that, really it's a financial assistance program that you need to dig in and to validate that, designing programs around around this make sense. We dug into food security details for state Medicaid. We defined the counties where food security, we'd say, food security is going to have a low impact on moving the needle for the total cost of care, for the overall health of this population. There are other counties where, addressing food security is very important, and calculating that's going to really move the needle for the group. For that to be true, that means that if there are food security areas that are well addressed, we should see gains. So we did an analysis where we went and we identified from publicly available sources where the food banks were in Oklahoma, did calculations of the approximate number of Medicaid members per food bank in each of those counties. And you can see the first row there, which is the counties that we said, food security is not going to move the needle here. You can see that the per member per month cost actually increased with access to food banks. Not really enough of analysis to unpack that increase. Was it due to improved access to additional utilization? Were there other programs going on in conjunction with the access to food that really drove that? Other community programs that we don't have the answer to that. But what we do know is that when we move to the group that we said, this is a moderate impact that we're expecting. As they moved from not having food banks to having food banks, there was a $15 to $20 per member per month savings in that group compared to the counties where we said, food security is a big issue for these groups. They actually had a 45 to 50% per member per month cost savings by having access to food banks. That left 8 counties in the moderate or high impact that did not have, 9 counties that did not have food banks, and we were able to identify that in 8 of those counties there was about a $6.6 million opportunity by solving food security in them, and there was one county that if they were able to address food security in that one county, was a $3 million opportunity, or about a $10 million a year statewide opportunity from dealing with food security in areas that did not have food banks. We've seen these programs be really successful for ACOs and for Medicaid programs because the food banks are typically very interested in getting to these populations, to completing their missions. We have a partner in Georgia that's working with the Atlanta Food Bank, and what they've done is they had a McDonald's that closed. Their lease has now gone to the Atlanta Food Bank. They're allowing the Atlanta Food Bank to have a food pantry in the hospital without paying for the lease. The rest of the cost of delivering the food is covered by the Atlanta Food Bank, and those people that are being identified at highest risk at both the individual level and at the community level, are referred to that food bank. They'll leave the hospital with good food after discharge. They can go there after clinic visits as well. So the ability to tackle a specific program and know that it's going to have a return for the health of the population definitely can be done with the level at which SDOH can be analyzed today. We really haven't seen the indexes be able to drive this. If you look at the CDC social vulnerability and look at something like total cost of care, there's very little correlation. The correlation values there tend to be less than 0.1. Whereas when you look at it from an AI perspective, you're getting correlation values of 0.85, 0.9, 0.95, and really know that there is a driver between that vulnerability and the outcome that you're looking at. But if you're going to build a program, it's good to build a program around, data that can be tracked and data-driven decision to make sure that you're not just making donations that are good and driving positive outcomes for people, but might not necessarily be moving the needle in the way you intended, or you can make a really big impact simply by allowing a food bank to work out of your health system and provide good access to your patient population. And with that, I'm going to hand it back over to Mackenzie, and I appreciate your guys' time.
Fantastic. Thank you so much, Dr. Showalter and Amy, for sharing some of those insights. We so appreciate it. And, we would also like to get Dr. Bonnet involved in the conversation and hear some of his insights on the topic as well. So, Dr. Bonnet, let's just jump right on in. From your perspective,
Sure.
Who are the stakeholders that need to be around the table when crafting a health equity strategy? And maybe you can share some specifics about those who are involved at your own organization.
Of course. And thanks again for having me today. A couple things, I want to just take a step back because I think John said a number of things that resonate and should resonate with people. And one thing that stood out to me that he says that these are addressable problems. And I think that these, and we need to break them up into the components that are addressable. And so the way I think about this, and as we have thought about it, and then I'll answer the subsequent question in a moment, is we need to stop thinking of these things as someone else's problem and that they can't be fixed. And so most of the time, and in our experience, when we have talked about social determinants of health, a lot of times that gets tuned out because it appears to the average clinician like it is too large of a problem. And so there is the social and ethical component of this, and then there's the financial and the pragmatic. And the social and ethical looks at poverty and says, I can't do anything about that, and so it gets shut down. So, and what we have done is, you may not be able to solve a food desert that's 25 miles in any direction. What you can do is identify that that's a key driver for, one of your patients, and you can spare them a readmission or other kinds of things that will help. Now, the financial and pragmatic model, or the aspect of this, historically, if a patient goes home and has food insecurity and comes back to the hospital, in a fee-for-service world, that's a win. But in a bundled payment world, it's not going to be. And so getting back to the original question, Mackenzie, who needs to be involved? At the core is we have to engage the provider and make this part of the day-to-day vernacular for our organizations, for our practices, for our health systems. It also needs to be very important to leadership. And by leadership, I mean physician leadership, nursing leadership, any kind of operational leadership. I mean, this has to be a priority, and it breaking it up into those terms, I think makes it easier for that to be part of any kind of med staff. A couple of other additional things that might be thought of that we encountered is both legal and compliance need to be engaged in this. We live in a world where people are worried that, Apple and Google are tracking you. So when we start asking about these kinds of issues, people become suspicious. And why are you asking me this question? Why are you asking me about food or transportation or where I live or how many people are in the house with me? You do get that kind of reaction occasionally. And I am a clinician. I mean, I'm still 40% clinical despite my other responsibilities. And so when you start to probe these issues, people, sometimes people can become uncomfortable. So it's also important to partner with trusted community leaders outside your health system or organization. So those are several examples of people that we have engaged to try and, identify and find the key drivers to some of these problems.
Absolutely. I appreciate you sharing that. It sounds like it really is, an all-team effort. And like you said, it really is an addressable problem. You can't think of it as someone else's problem. Everyone has a stake in it. And going off of that, can you talk more about how you've worked to elevate the conversation at your own organization? And how do you really plan to continue to make health equity a top priority?
Well, it's interesting. I think most hospitals these days, health systems have initiatives around readmission and length of stay and all kinds of metrics. And as we have helped break down fractally all of these into their core components. So what is driving, certain metrics in our community? What is driving certain DRGs or demographics to have poorer health or to readmit more frequently? We've identified, and using electronic tools and platforms, data and analytics and other kinds of AI tools, including Jvion. We have more and more identified, drilling down into certain demographics. For example, heart failure. Why are certain heart failure patients readmitting? And just going beyond, the day-to-day, what do they need to prepare for at discharge, you learn all kinds of things. Well, there is food insecurity in one patient, or another patient has no transportation, or another patient can't get their medicines because there's not a pharmacy within 10 miles of their home. There is not a PCP within 10 miles of their home. And so once you start to identify things like that to a clinician, including myself, that starts to seem more manageable than, say, quote, eliminating poverty, unquote. And that's an actual direct quote from a med staff meeting that I attended. Once it seems less like this monolithic, societal problem that that a single person can't do anything about, then it becomes something that can be organized, a project organized around to benefit a great deal of patients. Because at the end of the day, all of us got into medicine because we want to help people. We want to do the right thing for our patients. And to the extent that we have the ability to do that and can be equipped to do that, physicians, clinicians, any kind of physician provider, the more they're able to be equipped rather than have to invent it out of whole cloth themselves, the easier it tends to be.
Absolutely. And I'd love to zoom in more on that care delivery piece. Can you talk about how this urgency around health inequities is changing the ways in which care is delivered and coordinated?
Oh, yeah, absolutely. I think because people are realizing, this goes back to kind of what I was saying earlier. CMS is the biggest payer in the United States to the tune of 65% of all claims. They have signaled very clearly that they want quality and value to continue to grow in an at-risk model, meaning that if you do well and you eliminate these defects in care, that you will benefit, and if you don't, then you will pay them back for the difference. So they want physicians and hospitals on the hook for the quality and value that patients receive. Increasingly, we're seeing a lot of the social determinants of health and equity as contributors to the financial imperatives that drive most hospital projects and metrics. And so we increasingly see, that there is, and not just from the crass financial standpoint, but we're also seeing that we have historically tended to look at our metrics as kind of one-dimensional, is if I just do this one thing, that'll solve, readmissions. But people are complex. The problems are complex. And so as we have noted, as an example, we had this conversation earlier today, is we can create checklists and processes and until doomsday. But if the problem is that the patient doesn't have enough to eat, then we're addressing the wrong problem. And so, for everything that we do to drive our metrics, as we look at our management system of how we do it, even before we create goals of what we want, have we taken the time to adequately analyze the problem? And I think that's, there's increasing urgency around that, and keeping that notion as part of our day-to-day vernacular in our huddles, in our practices, with our practice managers and teammates, colleagues. So I think you're seeing how much that inequity is driving some of our metrics, and I think that was very evident during COVID. It really kind of got unmasked during COVID in a way that was undeniable. And then at that point, then you can say, well, let's, is our current solution the right one for this problem, or are we addressing the wrong problem?
Yeah, and I'd love to talk more about, that piece of addressing the problem once you accurately identify it, which sometimes I think can be easier said than done, but not impossible. In your opinion, what has been the greatest challenge for organizations in terms of actually acting on social determinants of health?
I would have to say translating social determinants of health and what the individual provider can do into something meaningful for them. And I don't mean just in terms of financial. In fact, I mean, quite the opposite. Yes, we're all going to have, quality incentives and those kinds of things, and those are all fine. I think there is evidence in the literature that suggests that financial imperatives alone are not as effective. But as I mentioned before, clinicians are extremely busy. And so, I am one, I have been on the other side of this where a manager or a CMO comes to you and says, hey, we really want you guys to do this. And, the first reaction is and should be, how are you going to equip me to do that? What tools can you provide for me? How can you put this in terms that are meaningful to me? How can you show me meaningful outcomes if I do this? And that's, I think, been our biggest challenge is developing that script. Maybe is maybe a poor choice of words. Developing the culture of this is what we should do, this is why we should do it, and this is why it's important to you as a frontline provider, whether you're a nurse, whether you're a physician, whether you're honestly a janitor. I mean, it's great. My boss, who's a fairly well-known name in quality, tells a fantastic story about going to visit a aircraft carrier, and this airman that he spoke to, his job was to sweep the deck. And when he asked him what his job was, he said that his job was making this safe for the pilots and the proper the proper running of the ship. He didn't say, "Oh, I just got a crummy old job sweeping the deck." I mean, we have to have that view of culture in our organization to be successful at this. I mean, it has to be a priority, and so getting it to be a priority when everyone has 100 different priorities has been challenging. But I think we're making progress. I think, particularly as we've engaged with community leaders and people feel rewarded for doing rewarding work. That has never been quite as obvious as when we started doing the COVID vaccine clinics in lower income parts of Cleveland. The just personal reward for that from anyone who did those clinics was tremendous. It was more than any financial incentive could have done. And so they felt rewarded for doing the right thing. And so that, it has been a challenge, but not to say that progress can't be made in this term.
Absolutely, and I love that anecdote you shared. I think very powerful and a good example of the culture, like you said, that's just so needed. I'd like to switch gears just a little bit and talk about patient-provider interactions. How does having social determinants of health insights inform those conversations?
Well, I speak primarily from my own perspective. I'm an internist. It causes you to ask different questions, and I don't know how many people on the webinar today were trained like I was, but I was not trained to ask the questions with the level of detail that may be required, say, to prevent a readmission, or to ensure someone is comfortable going home. I have long been a believer that length of stay, as an example, which is on everybody's mind these days, corrects itself if you correct readmissions. If you get people more comfortable with sending people home, they will, because most people want to go home. So it causes you to ask different questions. It causes you to make different observations. And it often it helps you to incorporate somebody's lived experience into your assumptions. I guess is the best way to say it. We all come from a particular cultural, ethnic, perspective. We can't avoid it. And those biases are built into us. I mean, we're just naturally, not by being American or being any particular ethnic group, but, we are always tend to notice what's different. What we don't notice is what's hidden. And so that's the kind of thing we have to teach ourselves to ask about. And my patients, quite honestly, have taught me more about this than any conference or anything else. I've learned a lot from them, and over time I've learned to know what to ask. And particularly in the last year or 2 years or so, as this has become part of more of the national conversation, I think it becomes easier to start thinking about those questions, not only during individual conversations with patients and their family, but also those of us who have a broader reach or broader responsibilities. It allows us to help make those conversations a priority about who we want to be as an organization, where we want to take both our systems and our communities, and how we can get there.
Absolutely. It's interesting to hear your perspective on that. So I appreciate you sharing. I think the last big topic I want to acknowledge and ask you about is really just the fact that we know hospitals and health systems can't do it all on their own. So what role do payers and or other community organizations have to play in helping to address health inequities?
Well, I think we criminally underuse our resources within our payers. Not only do I think they have a responsibility, which is beyond the scope of this talk, but we tend to underutilize what they can provide, often because we don't ask. For example, we don't utilize payer case management for specific demographics of patients. The payers have every interest themselves in keeping these patients out of the hospital. So what can we leverage? And I think to some extent that has to be led by our hospital and other leaders that are familiar with navigating that realm to some extent, not exclusively, of course, but I think it's incumbent upon me as a physician leader to to reach out and start establishing those conversations. Hey, payers, what have you done for me lately? It's not, to the point of the question, it's not, can't, solely fall on the shoulders of providers or health systems. We're all on the same team ultimately for improving health in our communities and reducing harm, reducing defects in care, and how are we going to do that together? And what I have found personally in my dealings with our payers is that they are they don't seem to be willing to volunteer it, but when asked, they will often provide resources, whether that's case management input or other kinds of oversight, patient calls, other kinds of things that will help. I've found.
Wonderful. Well, Dr. Bonnet, thank you so much for all of your thoughtful insights today alongside Dr. Showalter and Amy. We so appreciate your time. With the last 10 minutes or so of today's session, I'd love to turn to the Q&A portion of our session. So for our audience members there, you can submit any questions for our presenters by typing them into the Q&A chat box you see on your webinar console. The first question, Dr. Bonnet, looks like it is for you. This audience member is asking, who leads the equity strategy work at your organization?
There's actually a team of people, ever increasing, which I'm happy to see. This is led by a team of people at the executive senior leadership level, including the CEO, but primarily our chief compliance officer and chief diversity officer. And then there is a chief governmental affairs officer, and then there are individual committees and projects underneath that report up to those groups. They tend to hold the larger regional community political relationships. Myself and my team are involved in that process as well. And that is how they organize it in kind of, you heard me mention earlier, a fractal structure, so that we could start identifying particular issues to target for the Cleveland area. And so that is how we have organized, and we're continuing to see results in that area slowly, but like any enterprise like this, it doesn't happen overnight.
Great. Thank you so much for outlining that organizational strategy. I think that's helpful for audience members to know. Another audience member is asking, can you please address population social determinants of health metrics versus social determinants of health at an individual person level?
I make sure I understand the question. I assume it's kind of what I was saying earlier. So right now, as I said, I kind of do break this up into a couple categories or a couple aspects. So as we look at social determinants of health in a population, there are key drivers that require different solutions. So, for example, if the issue, as for example in parts of Cleveland, where there is no grocery store or pharmacy for 20 miles, just a guess, just an estimate, that's a very different problem with associated, potentially, metrics for that population, and versus an individual group of patients who may or may not be from that area. So each issue may require a different solution. So I hope I'm answering the question. May require a different solution with different levels of leverage. So, and they might overlap at some point. So, for example, in the food desert in parts of Cleveland, it may require leveraging, mayor, police resources, political resources that are available to us to solve this problem for a broader group of people, right? Versus the person sitting in the office who doesn't have enough food and keeps readmitting because they don't have enough food. Well, that may have a simple, short-term solution. The long-term solution may be associated with the population solution. I think the difference between the population and individual level is, what levers are needed to address it often, because a lot of times these things overlap. The person sitting in your office may not have food for the same reason that everybody in his community doesn't have food. Or perhaps the issue is crime, or it is a lack of a pharmacy or lack of transportation. And I think the key issue is developing a framework in your organization that by which you can ask those questions openly, as well as build a framework for solutions. And that's why I think, I mentioned earlier that there's a lot of, enterprise level people that are involved in this. And I think that's important because some solutions of these may be, at a higher level than, a single, private practice can address, at least long term. So that, hopefully that was the answer. Hopefully that addresses the question. I'm not entirely clear on it, but hopefully that answers the question that was asked.
Yeah, Dr. Wan, I think I was thinking very much along the same way, you were, on, from whether it's the population or the individual, side, getting that actionability and, contextualizing the need to separate the signal from the noise is important.
Right.
I like the food access, question on the population level is really like who can action it, and maybe, a community level solution is, a grant that allows you to build a grocery store so that a grocery store chain can come in
Exactly right. Exactly right.
Right.
So on the one issue, it's maybe, sorry to interrupt you, but on the one issue, maybe it's equipping the patient with the resources or the transportation to get to a food bank. On the other hand, maybe it's someone who has a strong relationship with the senator who is a board member to leverage the grocery store that left and find them incentives to come back to the area. So it's two different problems with often the same solution. But I'm sorry to interrupt you, John.
No, exactly. And as I haven't practiced in a few years, but as a primary care doc, with the person sitting in front of me and identifying, a need, as I said, if you knew their insurance had a program, or if your health system or one of the nonprofit facility of the health system had a program, you say, hey, I'm really concerned about you getting your healthy food after discharge, please call this number, and they'll work that out for you, right, is very different than, as you said, working with, the senator to find leverages to bring the corner grocery store back that left because, Walmart kind of pushed them out of the area and they were no longer profitable, and now the only thing left is
to drive 20 miles to Walmart.
Yeah.
Right. Which is not necessarily reasonable. One of the biggest successes that we have had so far, and it's ongoing, is, in a 22 hospital system, is equipping our providers with knowing what the resources are. Because a lot of them don't know. They don't have the time to find out. And why should they? They're seeing, 25 patients a day. So, we're developing resources to help equip them and the people around them, support staff, practice managers, and other kinds of things, so they know what resources are available. And as those change, so does the information that they have available to them. So we want to automate that at some point, but that has been very successful because people have really eaten it up.
Wonderful. Appreciate you both weighing in there. Looks like we have time for one last question, which is, do you see different or improved health outcomes when the provider represents the patients they're caring for? How can organizations create a pipeline for more providers who are people of color? And Amy, maybe we could tap you for this one.
I'm sorry, is that addressed to me?
Sure.
To Bonnet or to Dr. Feller?
Amy, if you actually wanted to weigh in, and then I invite the other panelists to add on as well.
Okay, I'm the one who asked the question. But
oh, no worries. Yeah,
I mean,
then if Dr. Bonnet, please, whoever feels free to weigh in.
I honestly don't know whether the outcomes are better, at least in our organization. I think the literature would imply that they are, but one wonders if that in itself is a defect because, providers, say, of a different representation are not properly equipped to deal with someone of a different representation. So two questions here. So maybe a different question would be, how do we better prepare all of our providers to demonstrate equity and prepare them to properly care for somebody of a background different than themselves. As for the latter part of the question, how do we incentivize, or how do we create pipelines for more Black, Indigenous, or people of color providers? I think that's a great question, and I think we need to be encouraging that for a variety of different reasons. And how do we empower those who are within our purview, whether teaching services or, other kinds of things, to encourage them. I certainly think there are financial incentives. I think there are representation and leadership opportunity incentives, which I have found personally very, very helpful in attracting some of those. I still think there's tremendous amount of work to do, but not just at the medical school level, down below too. I mean, our leaders should be encouraged and incentivized, and I don't mean just with money, but incentivized with time, to be spending part of their time in schools where they can inspire, to inspire people early to dream and get involved in their own community and in the healthcare system at large. I hope that answers your question, Amy, from my perspective.
Sure.
Perfect. Well, that is all the time that we have left for today. So I just want to thank our speakers again for having such an important, insightful conversation today. And thank you to Jvion for sponsoring this webinar. To learn more about the content presented today, please check out the resources section on your webinar console and be sure to fill out the post-webinar survey. Thank you all again for joining us, and we hope you have a wonderful rest of your day.